Hello. Hello.
Hello.
Anyone? Okay. So we have Dr. Urshi. So you are the only one who's going to attend this lecture, and along with one more doctor, I think Dr. NK. Right? Only two, you guys. Hello.
Seems like
Dr.
it's just us two.
Sorry.
Seems like it's just us two. I don't see anyone else.
Okay. It's okay. So it's a recorded lecture anyway, so they can listen some other time as well. Because I wanted to cover this lecture because this is something which we skipped because of Eid. So now I want to cover all these topics because tomorrow we'll be having a class on LGBT and cough. So I don't want that day to be really long day. Okay, that's Fridays. Usually Friday should be smooth and short. Okay, so that's why I'm going to do a class today. Okay, so we have certain topics that we haven't covered yet. First is ophthalmology, eye. Then we have some ear-related cases, and ear along with some dizziness, okay, and these things. And then we have one more type of cases, which is your follow-up cases. All right. So other than Dr. Arshi, we have one more person in the meeting, Dr. NK. Can you please say hi, hello, or anything so we'll have an idea whether you're up or you're sleeping or anything? Hello, doctor. Dr. NK,
Yes, I'm here.
you're here. So because I don't want to keep on saying Dr. Arshi, Dr. Arshi, Dr. Arshi, okay, because otherwise it becomes exhausting for a single person to just respond. Okay, so first topic of discussion is going to be ophthalmology. Okay, what is your prior knowledge regarding ophthalmology? How do we take history of ophthalmology cases? Who's going to tell me? Doctors, how do we take history of ophthalmology cases?
Okay. First of all, we'll do our normal grips. We'll
Like what?
start with. Yes, you said?
Please take history.
Yes, we'll take grips. That's in do a grips. Get to know, greet the patient, introduce yourself. Um, you then you take the history of presenting complaints. The patient may
Okay.
present with maybe redness of the eye, pains or
Okay.
discharge. So you want
All right.
to depara as the case may be, or you want to, if it's pain, you want to do your normal clicking for pain. Then after that, yes, you want to rule out your differentials. Okay, so redness, discharge, you talk about halos around the light. You talk about the past medical history. Talk about if it's on any previous medication, allergy. You talk about the family history of any medical condition. Talk about the social history. You ask the patient, then you do your examination. Then you explain the diagnosis to the patient, then you manage the patient.
Thank you so much, doctor. Okay, so ophthalmology history, basically, there are certain questions that you have to ask all of the patients of ophthalmology, okay, all eye-related cases. And then we have some specific questions which are different from, one case to another, because these are your differential diagnosis questions, okay? So first thing, every part of your body which is present in form of pairs, you have to ask about which eye, okay, and what about the other eye, okay? So the first question in this ophthalmology cases is usually whenever patient says that, okay, doctor, I have blurring of vision, I have eye pain, or, I cannot see anything, okay? So you have to ask, okay, are you having this complaint in one eye or both of the eyes, okay? If one eye, then which eye? What about the other eye, okay? Then are you able to see if the patient is saying that, doctor, I have pain, what are the other things that you have to ask? Okay, are you able to see anything, okay? Is it painful? Is it itchy? Any bleeding or any discharge? Okay, any watering from your eye, right? Or did you sustain any sort of trauma? Okay, any contact lenses, any fever, and any foreign body. Okay, have you ever noticed that? Have you experienced any foreign body that went into your eye? Okay, so these are 12 questions that you have to ask in all of the ophthalmology cases. Okay, am I clear about these 12 questions, or should I repeat these 12 questions?
No, you're clear.
Yes.
Okay.
Yes, we're clear.
So once you're done with these set of questions that you have to ask in all of the cases, then you are going to ask about some specific questions, okay, that varies from one differential to another differential. All right. Once you're done with this, first thing is your Otipara, Fotipara, or soft rates, depending on whether patient is having blurring of vision or pain. If pain, soft rates, and then these 12 questions. If patient is having blurring of vision or patient is having any disturbance in the vision, Otipara, and then these questions. Okay. Then your differential diagnosis questions. Okay. Next thing is your psychological history. Okay, because a person is experiencing something related to the eye, so it will have some psychological effect on the patient. Okay. In this the set of questions, you have to ask about what does the patient do for living. Because if he is a student, or if he is doing any job which really requires good vision, okay, actually each and every job requires this vision thing. But there are some specific jobs in which you have to have, a 6x6 vision. Okay, so what type of job he does, okay, and how it has affected his life. Okay, can he work properly because of the despite of this thing or not? Then can he do his day-to-day activities or not? Okay, because this is related to the vision, so it will have some effect on his day-to-day activities or day-to-day life as well. Okay, then your P Mathosa or FMAM. Okay, once you're done with this, DESA, in some cases, DESA is very important. We'll discuss shortly about those cases as well. Okay, then eyes, then examination. Always remember that in the cases of this ophthalmology or in eye-related cases, whenever you have to examine the patient, please please tell them about the chaperone. Okay, in eye examination and in ear examination, where are you standing while doing examination? Here. Okay, so you cannot go this close to someone without asking for the chaperone. Okay, so you have to ask for the chaperone. Okay, there are certain things which you have to check, which you need to check in different cases. Okay, eye examination in all of the cases. Visual acuity is very important in cataract. Okay, sugar levels. Okay, capillary sugar levels in diabetic retinopathy. Blood pressure in hypertensive retinopathy. Okay, visual field in glaucoma. Okay, or pressure inside the eye in glaucoma. Okay, and then fundoscopy. Mostly it is done, in all of the cases. Okay. So all of these things you have to mention in your examination. Okay. Once you're done with this thing, then you are going to tell the diagnosis. So in eye-related cases, we have eye pain, we have blurring of vision, okay, or certain loss of vision. Okay. So you're going to make your differentials depending on the fact that whether this condition was acute in onset or it was chronic in onset. Okay. So I'm going to enumerate some of the topics that we are going to discuss today. First is glaucoma, then cataract. You can just make a list, and then I will tell you which present as acute case, which will present as chronic case. Glaucoma, cataract, age-related macular degeneration, diabetic retinopathy, subconjunctival hemorrhages, conjunctivitis, retinal detachment, toxoplasmosis, episcleritis and scleritis, and arcus sinalis. Should I repeat the list? Or you
Yes,
guys?
please repeat, Dr. Sophia.
Okay. Glaucoma. Second is cataract. Then age-related macular degeneration. Okay, please make it like 1 point and just leave the space. Okay, because you have to write certain. Then diabetic retinopathy, subconjunctival hemorrhages, conjunctivitis, allergic conjunctivitis, retinal detachment, toxoplasmosis, episcleritis, scleritis, and arcus senialis. Am I clear?
Yes.
Okay. So since we don't have a lot of time, so I'm going to discuss all of these things. I'm going to tell you how this patient will present. Okay. So first thing is glaucoma. Now we are going to discuss glaucoma. What is glaucoma? Anyone? What is glaucoma?
Rise in intraocular pressure presenting as sudden onset pain in the eye.
Yes. Okay. So basically, glaucoma means whenever in your eye we have angles, right? So basically, what happens is whenever there is any blockage, okay, on the drainage system of the eye, what happens is that the aqueous fluid, it starts to build up in the eye, okay, and it would put pressure. That's why it will cause these complaints, pain in the eye, okay, along with nausea, vomiting, and some visual changes as well. Okay, so what it is raise in intraocular pressure. Okay, why? Because there was something wrong with the drainage system of the eye. All right, so that is your first case. Now glaucoma patients will present with acute pain. Okay, sudden in onset pain, which is sudden in onset acute pain. Okay, very severe pain. Patient can present with red eye as well. Red eye is also one of the features of glaucoma. Okay, other than that, this patient can present to you with with little drama as well, that they'll be wearing some sunglasses as well. Okay, because they will say that, doctor, darkness makes it better. Okay, whenever we go in the movie theater, or we watch movies in darker room, it gets better. Okay, sorry, it gets worse. Okay, so dark room makes it worse. Change in visual acuity, severe pain, along with some headaches and nausea, vomiting. What are the complaints of glaucoma patients? Who will tell me the complaints of glaucoma patients?
Sudden onset eye pain,
Yeah.
visual changes, headache, nausea, vomiting, and
Mm-hmm.
dark places or dark rooms make it worse.
Yes. Okay. Other than that, some hollows around the light. Okay. Some patient can present with the corneal edema as well, but that's not something that the patient can tell you. Okay. So if a patient presents to you with sudden onset of pain, eye pain, along with redness of eye, along with headaches and nausea and vomiting, this is glaucoma. Okay. Another very close differential to this glaucoma is anterior uveitis. Okay, but interior uveitis patients don't usually present with headaches or this nausea, vomiting. Okay, no associated complaints. Okay, so this is your glaucoma patient. Now you have to, after asking about this, since this patient presented with what? Pain, you have to take the whole Socrates. Okay, after the Socrates, take differentials, different differentials. Okay, first you have to ask these questions, that these complaints that I mentioned. Okay, because these are typical to glaucoma. Now we are going to make other differentials which usually present with sudden onset of pain. Okay, which are other eye complaints which present with pain? Painful red eye. What could it be? Doctor, painful red eye.
Trauma,
Trauma. Okay, and one just I just mentioned.
uveitis, anterior uveitis.
Anterior uveitis. Okay, what else? Trauma. Then, doctors, red eye, pain, sudden onset, scleritis. Okay, then we have other stuff like conjunctivitis as well, allergic conjunctivitis. They come with pain and red eye. Okay, so these are your differentials of acute onset of the pain, okay, along with red eye. Okay, your diagnosis is glaucoma. So now in cases of glaucoma, what is something that you have to do in examination? Check intraocular pressure. Okay, and there are two things: tonometry and genoscopy. Okay, tonometry means that you are going to check the intraocular pressure, and genoscopy means that you are going to check the angle. Angle is not something that you can really check at GP level, okay? But you can mention checking about the intraocular pressure, although it has to be done by seniors, okay? Now, once you have taken this history, now it's time for your management. I gave you the definition of glaucoma in the very beginning. Who will tell me the definition of glaucoma? Anyone other than Dr. NK? What's the definition of glaucoma? Dr. NK, what is the definition of glaucoma?
Glaucoma is when there is increased intraocular pressure due to blockage of flow of the fluid, okay, and that could result in painful red eyes,
Yes.
headache, nausea, okay. And there will be decreased in peripheral vision. So the patient will present with halos around the
Doctor,
light.
in your definition, in the definition, you don't actually have to mention all of the features that patient will present with. Okay, just give me the definition. Why this happened? Okay, this is raised intraocular, patient has raised intraocular pressure. Why this happened? Because there was some difficulty or some disturbance in the drainage system of the eye. Okay, now this one, this patient, since this patient has glaucoma is emergency. Okay, so this patient needs to go to the hospital today, okay, right now. So first thing is, if the patient is in the hospital, admit the patient. If the patient is not in the hospital, you are in GP clinic, send this patient to the hospital. Okay, now once the patient will reach to the hospital, or once the patient will meet the ophthalmologist, what will happen? They are basically going to re-examine the patient. Okay, they are going to perform some baseline tests, and they're going to check they're going to do the genoscopy as well. Basically, they check the angle of the eye. Okay, regarding the treatment, there are multiple treatments that you can do, that you can give in the glaucoma patients. The first treatment is the parasympathetomimetics, pilocarpine. Okay, so these drops, pilocarpine drops. Okay, these are something which will, what these drops will do. These drops will basically decrease the tension, the pressure in the eye. Okay, then what's the next medication? Acetazolamide. Okay, IV acetazolamide is something something which is going to lower the production of the aqueous fluid. Okay, so pilocarpine, IV acetazolamide, timolol. Okay, timolol is beta blocker, so it can also work because it decreases the pressure. Okay, once it is the patient has this pain has settled, okay, you can give painkillers and antiemetics as well. Once the pain has settled, the other management is laser therapy. Okay, in the case of this glaucoma, basically it is because of the iris. Okay, and it has to do with the tubercular meshwork as well. So iridotomy is something that we can offer. Not we, but other person, what the ophthalmologist. Okay, so laser iridotomy is your treatment for glaucoma. Always remember, glaucoma is an emergency and you have to send this patient to the hospital. This patient can say, and please ask him to remove the sunglasses. Okay, because this sunglasses, he will say that, doctor, my eye is red, so I'm feeling really shy. I don't want to take off my glasses. Tell him that, mydriasis, basically dilation of the pupil, it worsens your condition. Okay, so it can actually harm your condition and it can put your, your vision at risk. So please remove these glasses and go to the hospital. Okay, it is vision threatening disease. Am I clear about glaucoma?
Yep.
Yeah. Okay. The next thing, what was the next topic that I mentioned? Cataract?
Cataract, yes.
Okay. So in cataract is acute or chronic?
Chronic.
Chronic. Okay. So the patient will present with what? Blurring of vision or pain?
Blurring of vision.
Blurring of vision. Okay, so patient is having blurring of vision, and this is not an acute case. Okay, this patient is having this for years. Okay, so the patient will say that, doctor, I've been having this blurring of vision for years, right? And my vision is getting worse day by day. Okay, I am wearing reading glasses, and I feel that my reading glasses are not working. Okay, this patient can give you certain things which actually makes the cataract worse. Okay, any medical condition which requires steroids. So anything which makes the immune system worse, or anything which basically which will make him more immunocompromised, it is going to make his condition worse. So any immunocompromised condition state, okay, or any medications like steroid, okay, and smoking. These are most common risk factors of cataract. Along with that, the age as well. Okay, most people when they age, they do develop this cataract. Okay, what are the 12 questions that I mentioned initially that you have to ask in all of the patients?
So which eye do you have difficulty in seeing from? What about the other eye? And then
Mhm.
the entire OD para for it. How long has this been going on for? Anything that makes it better, anything that makes it worse? And then apart from that, any pain in the eye, any redness, any discharge, watering, pus, bleeding from the eye, any trauma, any history of contact lens use or any foreign body in the eye.
So once you're done with these things, you are going to ask some typical questions of the cataract. Okay, what are the typical questions of the cataract? Glare. Okay, this patient will say that, doctor, I do find glare, and these lights, they appear brighter. Okay, and I have blurring of vision. These are some typical complaints, and this is happening for a year. Okay, also when you will inquire about some medical background, the patient can say, the doctor, a few months ago, the doctor told me that there's something wrong with my lens, and he advised me to go for the surgery, but I didn't go for the surgery. Okay, so maybe it is because of that. So he already gave you a history of cataract. Okay, as you all know, the cataract is not something which will go on its own. Okay, it needs surgical intervention. Okay, so that's one thing. Now we'll discuss the differential diagnosis. What are the differential diagnoses in this case? A patient who's having blurring of vision for a year or quite some time, and the patient is old age.
Age-related macular degeneration.
Age-related macular degeneration. What else? What else? Diabetic retinopathy, hypertensive retinopathies.
Yeah, yeah.
Okay, these things, these are not so as such acute. Also, one thing, this iris analysis, it is something which presents with a very long-standing history that I am having this ring in my eye for a year maybe, but it's not something which is going to affect the vision. Okay, so that's the only difference in this case. Okay, now you are going to take the history about these differentials. Why I'm making differentials in all of the cases? Because once you know the diagnosis, when you will be standing outside the cubicle, and when you will read the case, you'll already have an idea that this is cataract. Okay. What students do is, when they enter the room, they straight away just take unidimensional history of cataract without making any differentials. So when you don't take any differentials, the history looks scripted. Okay, and it becomes really difficult to pass that station. So that's why I am mentioning these differentials, that you have to make these differentials, ask the questions regarding these differentials as well. Okay. Now there are some risk factors of this cataract. First one is smoking. Okay, alcohol consumption, anything which is making this person immunocompromised, diabetes mellitus, long-standing history of taking steroid. Some patients, there are some patients who are having PMR, okay, and they are taking steroids for that, or any metabolic changes. Okay, these are your risk factors for cataract. Okay, and patient is presented with decreased vision. Okay, patient may be experiencing some sort of faded color vision as well. Okay, glare around the light, that's really important. That's one of the typical feature in this cataract. Okay? Follows around the light, right? So on your examination, what are the things that you're going to find in your examination? Anyone knows the red reflex? Doctor, anyone is aware of red reflex?
I mean, we did study it, but I don't exactly remember.
Okay, it's fine. So basically, red light, red reflex is basically an reddish orange reflection which is seen through the ophthalmoscope. Okay, when the light it hits the retina, all right, it shows this reflection which is reddish in color. But since this patient is having cataract, so there is one opaque thing in front of the retina. So do you think that you will find this red reflex in this patient? Doctor?
No.
Red reflex? No. Okay. And this is a really important finding because they give you this thing. My case was of diabetic retinopathy. I didn't even mention this red reflex, but on the paper they gave me this finding that there is no defect in the red reflex. So in cataract patient, there is going to be defect in the red reflex. In diabetic retinopathy or hypertensive retinopathy, there is no defect in the red reflex. All right. Okay, because there is nothing on the way to the retina. But in cataract, there is an opaque thing in front of you. All right. Other than that, what are you going to do? You're going to check you're going to do the ophthalmoscopy. Okay. Usually the ophthalmoscopy is done, after full dilation of the pupil. Okay. Normally in this case, in this cataract case, the fundus is normal. Optic nerve is also normal. Okay. On slit lamp examination, you're going to find the visible cataract. Okay. But you are going to get an idea of the cataract with this red reflex only. All right. So now we are going towards the definition of cataract. What is the definition of cataract? What is the definition of cataract? I kept on mentioning one thing.
Basification of the lens.
Yes. Okay. So thank you, Mr. John. From what you have told me, it seems like you're having a condition called cataract. Cataract is a very common eye condition in which lens of the eye gradually opacifies or becomes cloudy. Okay. When the lens becomes cloudy, it makes it more difficult for the light to reach to the back of the eye, which is retina, which causes this reduced or blurred vision. Am I clear, or should I repeat this definition? Because you have to tell them why they cannot see. Doctor, should I repeat the definition?
Yes, doctor.
Okay. So basically, Mr. John, from what you have told me and from my examination, you're having a condition called cataract. Cataract is a very common condition of the eye in which the lens of the eye gradually opacifies or it becomes cloudy. Okay. When this lens becomes cloudy, it becomes difficult for the light to pass through it and reach to the back of the eye, which is retina, which is responsible for the vision. That's why you are experiencing blurring of vision or reduced vision. Okay. Am I clear now?
Yes, doctor.
Okay. So what we are going to do for you, we are going to refer you to ophthalmologist. Now, this is not an urgent referral. Okay. This patient can wait. Okay. It's not, this patient does not need urgent surgery. Okay. So in this case, you can ask this person to use better glasses and avoid contact lenses and everything, and you can encourage this patient to use brighter lights, okay, for studying and everything. But the definitive treatment of cataract is surgery. Okay, so what they are going to do for you is they are going to remove this cloudy lens and they are going to replace it with the new one. Okay, and in this manner you will be able to see properly. Okay. Now, if you have time in this station, you can mention some of the complications of cataract surgery. Okay. Complications of cataract surgery is retinal detachment. Okay. This posterior capsule rupture or any inflammation. Okay. Infection, inflammation, or retinal detachment. But the treatment for cataract is surgery. Am I clear?
Yes.
Okay. So then why do I feel today I'm just delivering a lecture as if I'm talking to PLAB 1 students somehow? Because eye-related cases are really simple. I don't know what to say. And these are very straightforward cases, so I don't have to repeat the script. Okay. So the next case is what? Age-related macular degeneration. Now, what is age-related macular degeneration? What is age-related macular degeneration? Any idea? No idea? Okay, it's fine.
The degeneration of the nerves supplying the macula, so central vision is lost.
Nerve or photoreceptors? Nerve or photoreceptors?
Photoreceptors?
Yes. So basically what happens is in the eye, we have a region called macula, which is responsible for the vision. Okay. This one, if this patient is going to come with the bilateral blindness, okay, or vision issues, not blindness, but blurring of vision, but it has to be bilateral usually. Okay. Basically, you can write the definition right now because otherwise I would have to repeat the same definition at the very end. Okay. Age-related macular degeneration, it is degeneration of retinal photoreceptors. Okay. Because of this degeneration, patient cannot see properly as the receptors are not working. Usually what happens is basically that whenever there is degeneration of these photoreceptors, there is formation of drusen, okay, which you will see in fundoscopy and retinal photography as well. Okay. Mostly this age-related degeneration is common in the females. Okay. What are the other risk factors? Please write the risk factors as well in this case too. Okay. In the previous case, you have written the risk factors, right?
Yes.
Please write the risk factors in this case as well. First is age, as it is age-related macular degeneration. Second is smoking. Smoking actually it puts you on the risk twice. Okay, so smoking. Second, now third thing is family history. And fourth is any patient with any ischemic disease, any heart-related condition, any diabetes mellitus or any hypertension or increased lipid levels. Okay. Now, these patients are going to present with some typical pains. The complaints. First is blurring of vision. Also, they can say the doctor, straight lines, they appear blurry. Okay. And, I have distortion of the line perception. This is typical of age-related macular degeneration. Okay. Am I clear?
Yes.
Okay. So, what else the patient can say? The patient can say that, there is that he is having photopsia. What is photopsia? It is basically perception of flickering or flashing lights, okay, or glare around the subjects. Okay. And he will have visual disturbance that varies from day to day. Okay. Now, this patient, as we know, the age-related macular degeneration, it has two types. First one is dry and second one is wet. Okay. In dry age-related macular degeneration, it is usually the early case in which the photoreceptors are not working. There's degeneration of photoreceptors, so there is formation of drusens. All right. While in wet macular degeneration, there is development of new vessels as well. There is new vascularization. There are hemorrhages as well. There are microaneurysms as well. Okay, so it is more severe condition. Okay. Once you're done with the history on your examination, same examination, ophthalmoscopy, red reflex, everything. Same differential diagnosis as we discussed in cataract. Now, on your management, first thing is your definition that you've already given. Okay. Second thing is we are going to refer you. Again, this is for this patient, it's not extremely urgent, but you are going to refer this patient. Okay. Now, for this patient, you are going to tell that once you will be there at the specialist office, they are going to perform certain investigations like slit lamp microscopy, fluorescence angiography. Okay, slit lamp microscopy. This is basically initial investigation of choice. Okay, it identifies the exudates and then fluorescence angiography. Okay, that is basically to check if there is neovascularization or not. Okay, and then optical coherence tomography. Okay, so these are some tests which specialist is going to perform. You're not going to perform these tests. Okay, once the diagnosis is made, this tells the patient that the management, it will be depending on your type of this age-related macular degeneration. All right. For example, if the patient is at the early stage, or the patient is having dry type of age-related macular degeneration, then you don't really have to do anything. Okay, he can just change his glasses. You can give him some multivitamins, zinc, vitamin A, vitamin C. Okay, these are really good. Okay, and if the patient is having some moderate changes, moderate dry age-related macular degeneration, then you can go for different treatment options. Okay, like laser therapy. Okay, other than that, you don't really need anything for dry type. Okay, so definition: refer this patient to ophthalmologist. Usually, you can refer this patient within a day. Okay. Today, what the ophthalmologist is going to do: slit lamp examination, fluorescein angiography, okay, ocular coherence tomography. Okay, please at least remember 1 or 2 names. Okay. For dry type, there is usually no treatment. You can just give some of the multivitamins, okay, some zinc supplements, okay, and he can use better glasses. Okay. And dry type actually doesn't go worse within days. Okay. For the wet type, the patient will need some management. Okay, the management is going to be anti-VEGF injections. Anti-VEGF injections. Along with that, laser therapy could help this patient. Okay. Since this patient, this age-related macular degeneration, it is also linked with some lifestyle changes. So advise this patient about healthy lifestyle, quit smoking, do regular exercise. Hyperlipidemia is also one of the risk factors for this thing, and CVS related condition is also one of the risk factors. So better lifestyle, keep your BMI in check. Okay. If you are having any difficulty in vision or anything, please come back to us. Am I clear?
So this is a same day refer, specialist
Yeah,
refer.
same here.
Okay.
But it's not immediate. It's not like emergency.
All right.
Now, the next case is diabetic retinopathy. Okay, apart from the first case that we discussed, glaucoma, the second one, cataract, age-related macular degeneration, and diabetic retinopathy, all these cases are basically differential diagnosis of each other. Okay, because these are not the patients who present with you with some acute complaints. Okay, they're having this issue for longer period of time. Okay, so in this case, they will give you an idea that this patient has already been diagnosed with type 1 or type 2 diabetes mellitus. Okay, and he is doing some lifestyle changes. He is having better diet just to keep his diabetes mellitus in check. Okay, another thing that they can give you, that this patient does not check his blood sugar levels normally. Okay, and he is not really practicing really healthy lifestyle, although he is advised to do so. Okay, and he has some concerns regarding the vision. Okay, that he cannot see clearly. Again, all these 12 questions. Okay, then differential diagnosis questions. Now, in this case, you already know what are the differential diagnosis, what are the typical questions in diabetes mellitus, diabetic retinopathy, diabetes related questions. Okay, if the patient has developed one complication of diabetes, please ask about the other complications of diabetes as well, which is urinary complaints, okay, or any neurological complaints, or any pin and needle sensation. Okay. Now, for this case, diabetic retinopathy, who is going to give me definition of that? What is diabetic retinopathy, and how are you going to tell this to the patient that you're having a complication of diabetes mellitus? Doctor, what is diabetic retinopathy and how are you going to tell this to the patient?
Okay, diabetic retinopathy is when there is visual when there is visual impairment due to complication of diabetes, uncontrolled diabetes. So I will tell the patient that you are having visual impairment because your diabetes, your sugar level has been uncontrolled for a long time. So you are now coming down with complications, which is visual impairment.
Thank you so much, doctor. So what is diabetic retinopathy? So tell this to the patient. Thank you so much for answering my question. So from what you have told me, as we all already understand that you're having a condition called diabetes mellitus. In diabetes mellitus, basically what happens is that there is increased sugar levels in your blood. Okay. Now you have developed a complication of diabetes, which is diabetic retinopathy. That means that this increased sugar level is actually damaging back of your eye. That is why you're having this blurring of vision, or this is causing any sort of blind. If the patient is having blindness, then you can say that you're having blurring of vision or blindness. Right? Am I clear?
Yes.
Okay. So what we are going to do, send this patient to a ophthalmologist. Okay. He will do is, we mentioned this thing in the previous case as well, fluorescein angiogram. Okay. Basically, we want to check the blood vessels, right? So fluorescein angiogram is something that he is going to do. Okay. And what is the treatment option in diabetic retinopathy?
I think you're also be give anti-VEGF injections.
Yes, but it depends on at which level this patient is having this diabetic retinopathy. Because see, diabetic retinopathy can present in non-proliferative one as well and proliferative one as well and maculopathy as well. Okay, so tell this to the patient that the treatment for diabetic retinopathy depends on your stage. Okay, stage of diabetic retinopathy. If you are at early stage, so they will tell you to maintain your diabetes mellitus or maintain your blood sugar level, so you won't develop this complication. If you are in advanced stage, then they can give you certain treatment options like anti-VEGF injections, laser therapy, okay, for the new vessels. All right. Some for some patients, if there is any inflammation, then they can give steroids as well. Okay. And most important thing in this case is lifestyle modifications. Have a healthy lifestyle, okay? Please exercise a lot. Please keep your BMI in check. Stop smoking, okay? And go to the diabetic clinic as well to keep this diabetes on check as well, okay? Now, these are some cases which are usually present with the long-standing history. I'll discuss one more case with the long-standing history, which is arcus senialis. So arcus senialis patient, it usually presents in GP, and the patient will say, the doctor, I have ring in my eye. Whenever a patient says, the doctor, I have ring in my eye, and he's an old age patient, please keep in mind that this patient is having arcus senialis. No vision issues. Okay, this patient will not have any issues regarding his vision. Vision is spot on. The only thing that he is worried about is because it doesn't look good. Okay, so the sole reason of the treatment is cosmetic reasons. Okay, you will not find anything in his history. The only thing that you can be worried about or you can find is his cholesterol levels, okay, or any CVS related condition. CVS related conditions, cholesterol levels, and a ring in the eye. That's it. Okay. Now, what is this arcus senialis? Take the proper history for your exam on your examination. Fundus is normal. The back of the eye is completely normal, and there is a ring visible. Okay, by the naked eye as well. Okay. What is this condition? This condition is called arcus senialis, which means that there is formation of the ring in your eye. Okay, it can happen because of two reasons. The first reason is the age. Okay, advancing age with people who are elderly or people with advancing age, they develop this ring normally. Okay, another reason that due to which this can happen is increased lipid levels. Okay, so these are two causes of arcus sinalis. What are these two causes? First is
Age, and second is lipid.
high cholesterol levels. So you have to tell these two things to the patient. If it is written outside the cubicle that the cholesterol levels are normal, then tell him that, you know, we had two reasons there are two reasons for this thing. Okay, but your cholesterol level is normal, so highly likely this is because of the age. Okay, is there any need for the treatment in this case? Any referral or any treatment needed?
Required.
Hmm?
No treatment needed.
No treatment needed. Okay, no referral needed, no treatment needed. Just reassure the patient that it's fine. Okay, it's not vision threatening condition. And also, if the patient says that, doctor, is there any surgery for this? Is there any surgery for arcus sinalis? Doctor, is there any surgery for arcus sinalis?
I don't think there is.
Yes, there is no surgery for arcus sinalis. So the only thing that the patient can use is some contact lenses. Okay, because the only issue that he's having is that it doesn't look good. Okay, so he can use some cosmetic lens for that. All right. Now we are done with all of the cases which present with some chronic issues. Now we are going to move forward towards some acute cases. Okay. One patient, okay, we have 4 differentials with red eye. 4 differentials, write red eye and then write 4 things. First is subconjunctival hemorrhage. Second thing is episcleritis. Third thing is scleritis. And fourth thing is conjunctivitis. You can write actually glaucoma as well, but we have discussed glaucoma already, so that's why I'm mentioning. What are these 4 things which present with red eye?
Subconjunctival hemorrhage, conjunctivitis, scleritis, episcleritis, and glaucoma.
Okay, good. So first thing is subconjunctival hemorrhage. Now, subconjunctival hemorrhage is not something that the patient has to be worried about. Okay, the only issue is that the patient woke up in the morning and he saw that, okay, my eye is red. There is no pain, nothing. Okay, just isolated red eye. Now, what are different causes of this subconjunctival hemorrhage? First one is any trauma. Second, patient is taking any blood thinner medication, which can make the vessels prone to damage or prone to bleed. Okay. Third thing is that it happened, because of any miscellaneous reason. You don't know anything about it. Okay. First thing is, what was the first thing which due to which this can happen?
Trauma.
Trauma. Okay. Second thing.
Blood thinner use or missing.
Okay. So the patient, if the patient is not having any, in this patient, even if the patient is using some warfarin or anything, don't ask him to stop the medication. Okay, you can check the INR levels, but don't ask the patient to stop the medication because it is for some serious conditions. Okay, this is for the heart-related condition, so don't ask him to stop the medication. So just isolated simple red eye with no other complaint. Okay, this is subconjunctival hemorrhage. Okay. Who will give me the definition of subconjunctival hemorrhage? What is subconjunctival? Which part of the eye is subconjunctival?
Basically, our eyeball is composed of many layers. Okay, one of the layers are transparent and it's known as conjunctiva, and the layer just beneath it has tiny blood vessels, which is the subconjunctival layer, where one of the blood vessels have ruptured and you're having this redness.
Yes. Yes. Okay. So you have subconjunctival hemorrhage. Okay. What is subconjunctival hemorrhage? A layer beneath the subconjunctiva, which is transparent layer. Okay. There are the vessels in that layer, they have bursted or anything, or they have damaged because of any. You can incorporate whatever the history findings are. If there is any trauma involved, say that because of the trauma. If the patient is taking any medications, say that because he's taking medications. Okay. And this happened. This is called subconjunctival hemorrhage. Right? So what is subconjunctiva? A layer in your eye, we have a transparent layer. Okay. Beneath this transparent layer, we have multiple blood vessels. Okay. When there is any damage to these blood vessels, Okay, it can cause this condition. But it is not something which is vision threatening, so we have nothing to be worried about, right? So what we are going to do is nothing. Just reassure this patient, this hemorrhage, it will get clear in 1 to 2 weeks. Okay. Tell this patient that, see, this conjunctivitis, because this is hemorrhage. Okay. So in few days, this hemorrhage or this red eye, it will change color into yellow or orange or anything. So whenever there's change in color, to yellow or brown, please don't stress about it. Okay, this is how normally the bruises or bleeding gets better. Okay, so first thing is reassurance. Okay, hemorrhage, it will get better in 1 to 2 weeks. Okay, and there are the bruises, it settle in its own time. Okay, and they go to different color changes like yellow or orange or brown. Okay, before it fades away. So there's nothing to be worried about. Okay, but if you feel that there is any pain involved or you're having any blurring of vision, you have to come back to us. Okay, please wear, please don't wear any contact lenses, or please don't touch your eyes. Okay, or don't insert anything in your eye. Okay, and avoid rubbing. Am I clear?
Yes.
Okay. Now the next thing is conjunctivitis. Mostly in PLAB we have allergic conjunctivitis. Okay, basically, how are you going to differentiate between multiple conjunctivitis? One is viral conjunctivitis, allergic conjunctivitis, or bacterial conjunctivitis. Mostly allergic conjunctivitis patients, they have clear discharge. Okay, but bacterial conjunctivitis, they have some sticky discharge or some purulent discharge, right? So this is a patient who is worried about the red eye. Okay, the eye is also itchy. Okay, the symptoms are getting worse, and patient is having discharge. Okay, for allergic conjunctivitis, mostly the discharge is watery. All right. Other things that can be associated with this allergic conjunctivitis is history of hay fever, asthma, or atopic dermatitis. Hay fever, asthma, or atopic dermatitis. Am I clear? Am I clear?
Yes, yes.
Okay, so once you're done with the history, I'm not going to repeat all the history questions because we have discussed this earlier, okay, in the lecture. So once you're done with all the history questions, what is conjunctivitis? Conjunctivitis is an eye condition, okay, which is caused by infection or allergen, any allergen. Okay, in this case, since the patient will not be having any other complaint, okay, and the patient has history of hay fever, so this is because of allergy. Okay, so this is allergic conjunctivitis. Okay, so inflammation of outer layer of the eye. Conjunctivitis is inflammation of outer layer of the eye. In your case, it is highly likely because of allergic reaction. This is sometimes referred as pink eye. So what is the treatment? Nothing. Okay, just ask the patient to please don't rub the eye. Okay, clean the eye properly. How is this patient going to clean the eye? First thing, boil some water, then cool this water. Okay, and then clean your eye with this water. Okay, boil the water, then cool it down, then gently wipe this area of wipe this eyelashes and eye area. Okay, and keep it dry afterwards. Okay, if this patient and you can give this patient topical antihistamines and mast cell stabilizers. Both of these things are topical. Okay, meanwhile, avoid wearing any lenses, contact lenses. Okay, if the patient is aware of the allergy, the type of allergy he's having, please avoid those allergens. Okay, and try to change the pillow covers and everything which you are using. Okay, what is the safety netting? If there is severe pain, any discharge other than this colorless discharge, and if there is any change in the vision, please come back. What was the third case of this red eye? What was the third case?
Episcleritis.
Episcleritis and scleritis. Okay. What is the difference between episcleritis and scleritis? Anyone? What is episcleritis and what is scleritis? And what is one difference that you will find in the history of this patient? बच्चों कुछ तो बोल दो. Episcleritis and scleritis. Doctors, what is one thing that you will find in this case which is different? No idea? Okay. This patient, see, both episcleritis and scleritis present with red eye. The one most important difference is that episcleritis, it's not painful. Patient can have mild pain or irritation, but pain is not severe. Scleritis, in scleritis, pain is extremely severe, red eye with extreme pain. Episcleritis, no pain or mild pain. Red eye, mild pain, low and or no pain. Scleritis, extremely painful, red eye condition. Okay. In 50% of the cases, the episcleritis is bilateral. Okay. Now, what is episcleritis? Episcleritis is inflammation of episclera. Okay. It can be in one eye or both eye. In this case, in both episcleritis and scleritis case, you will find some autoimmune condition, okay, like any inflammatory bowel disease or rheumatoid arthritis. Rheumatoid arthritis and inflammatory bowel disease, these are the diseases that you will find in the history of episcleritis and scleritis. It's not typically present in the rest of the cases, okay? But the only difference that you will find is, so Dr. Urshi?
Yes.
40-year-old man, he is having rheumatoid arthritis for 20 years. He's presenting with red eye. Okay. What's your diagnosis?
Could be scleritis or episcleritis.
Yeah. And how are you going to differentiate it?
So in episcleritis, he might have mild pain or irritation or no pain at all, but in scleritis, it will be very severe pain.
Yes. Okay. And see, how are you going to differentiate this with the conjunctivitis patient? No allergy history, nothing. Okay. Patient can present with some watering of the eye, but no prominent discharge. Okay. And what was that one more differential that we made? Subconjunctival hemorrhage. So how do we differentiate episcleritis with subconjunctival hemorrhage?
Subconjunctival hemorrhage would be absolutely symptom-free.
Yes, extremely sudden, just red eye, nothing. Okay, maybe some history of trauma or maybe some patient who is taking any blood thinner medication. That's it. Okay, for episcleritis, you are not going to do anything for the patient. Okay, it's a self-limiting condition, so manage it conservatively. No need to refer the patient. Patient can use some artificial tears though. Okay, so you can say that you can use some artificial tears, but this condition will get better. But on the other hand, one thing which is not for your PLAB 2, but one important thing in episcleritis and scleritis is whenever you are going to press the blood vessels in this case, okay, this red area in this in scleritis and episcleritis. Usually, this episcleritis, the blood vessels, they are mobile. Okay, so they disappear, okay, or they move. But in scleritis, the blood vessels, they're usually deep, so they don't. If you press this area or these blood vessels, all right. This is just for the knowledge. It has nothing to do with your PLAB. Now, for scleritis, on the other hand, it is an urgent referral. Okay, painful red eye. Okay, sudden in onset and a patient is having rheumatoid arthritis or inflammatory bowel disease, sarcoidosis, any autoimmune condition. Okay, refer this patient urgently to the ophthalmology. Okay, and this patient will need oral treatment. Same day referral to ophthalmology, oral NSAIDs. Please write down the management of the scleritis. same day assessment by the ophthalmologist. Oral NSAIDs, these are usually the first line of medications. Third thing is oral glucocorticoids or basically steroids. These are for severe cases or severe presentation. And any patient who has resistant this scleritis, he might need immunosuppressive drugs like methotrexate. Am I clear on subconjunctival hemorrhage, conjunctivitis, episcleritis, and scleritis?
Yes.
Yes. Okay. Now we have two more conditions, eye-related conditions left. One is this retinal detachment, and second thing is toxoplasmosis. So retinal detachment is again acute onset, no pain, nothing. The patient said that, doctor, I cannot see from single eye, one eye only. Okay, unilateral, I cannot see. It happened an hour ago, and it feels like a curtain falling down. Okay. When you will take the history, the patient can be having a history. Patient can say that, doctor, I had a cataract surgery. Okay, which eye? Same eye. When we were discussing cataract surgery, we discussed about the complications of cataract surgery. What was the complication of cataract surgery?
Retinal detachment.
Retinal detachment. So this is what this patient is having is retinal detachment. So what are the key features in retinal detachment? Other than Dr. Oshie, because the rest of the you guys are maybe sleeping or something. Do we have anyone other than Dr. Oshie who can say what's going on? No, I think Dr. Oshie, you're the only one who's listening. The rest of the guys are sleeping.
Okay. For retinal detachment, there is sudden visual impairment.
Sorry, what?
Sudden visual impairment.
Yes,
Visual
sudden
impairment
visual
of sudden
impairment.
onset.
Okay, curtain falling down, and patient can have history of cataract surgery.
Yes.
Okay, so now what is the definition of retinal detachment? Basically, in this case, you have to define the retina as well. Okay, so in back of our eye, we have a layer called retina. Okay, whenever there is separation of two layers of this retina, it is called retinal detachment. Okay, separation of two layers of retina is called retinal detachment. So what is the treatment option? Immediate referral to A&E. He has to go to the ophthalmologist right now. Okay, go to the ophthalmologist. Okay, meanwhile, when the patient is traveling or when he's going to ophthalmologist, please lay back while traveling to prevent further detachment. Okay, when he will reach to ophthalmologist, he is going to perform other tests as well. He is going to reevaluate his condition, and depending on that, he will give him certain treatment options. It could be simple, laser therapy or cryotherapy. They can go for scleral buckling, okay, vitrectomy. These are multiple options for retinal detachment. All right.
Okay.
Okay. Now the last case is toxoplasmosis. Now toxoplasmosis is not unilateral; it's bilateral. Okay. Patient is having blurring of vision, maybe some pain in the vision, pain in the eye as well, and this is for a month. Okay, a month or so. Please take the history of pets. This patient is keeping pets. Okay, so history of pet, bilateral blurring of vision and bilateral eye pain. Okay, this is toxoplasmosis. Okay, so in this case, what is toxoplasmosis? What is the definition? What is toxoplasmosis?
It's basically an infection caused by a parasite called toxoplasma.
Yes, blurring of vision, seeing maybe floaters. Okay, patient is not experiencing anything else, maybe some pain, no other thing. Okay, just blurring of vision and some pain. What this patient is having is toxoplasmosis. Okay, toxoplasmosis is an infection which is caused by a parasite called toxoplasma. Okay, the main host of this toxoplasma is cat. Okay, and this toxoplasma this toxoplasma for this toxoplasma, the main parasite, this is main human parasite. Okay, host is the cat, but it commonly acts on whom? Human. So how this patient got in contact with this with this toxoplasma, because he's keeping some cats at home. Now refer this patient urgently. Okay, you can refer this patient to ophthalmologist, and you have to refer this patient to infectious disease specialist. Okay, either refer, but mostly it is infectious disease specialist. He will perform some further investigation. He has to check the immunoglobulin levels and MRI as well, because toxoplasmosis can have some effect on the brain. Okay, so MRI, some blood tests. For immunocompromised patients, usually the medications or the treatment option is pyrimethamine and sulfurides. He has to take this medication for 4 to 6 weeks. Okay. Meanwhile, please avoid, dealing with the cats bare hand. Okay. Wash your hands thoroughly. Avoid eating any raw meat or any raw food. Okay. If you can donate the cats, please do. Because even if the cause is in your house, no matter how many times you are going to get yourself treated, this can happen again. Right?
Doctor,
So,
I have a question.
yes.
The infectious disease specialist refer is again on the same day, or is it?
Same day. You can just refer this patient today to the infectious disease specialist.
Okay.
It's the same day. Because he will diagnose this condition. Okay. Please keep in mind that in ophthalmology cases and also in the ear-related cases, it is very difficult to actually detect the finding on ophthalmoscope or on otoscope. So please make sure that you're asking all the right questions in your history, and you are getting the right, these typical features in your history, in your data gathering. Okay, the typical features that I just mentioned. There are some clues in all of the cases. So please keep in mind keep in mind about all these clues. Okay, if you have these clues in your head, you will make the diagnosis. But if you're not having any clue in your head and you think that you are going to detect this condition on ophthalmoscopy, it becomes really difficult, because see, even diagnosing any condition on ophthalmoscopy, even if you are sitting in your OPD, it's difficult. So do you really think that in exam setting, when you have a lot of stress and a lot of pressure, you will be able to detect it or find it in split seconds? It's not possible. Okay, and that exam area, the exam setting, it would be even difficult for you to hold the ophthalmoscope properly because of the anxiety. So please make sure that your data gathering, it has to be appropriate. First thing is your 12 questions, ODPARA, PODPARA, or Socrates. Then differential diagnosis questions, and only important differential diagnosis. If the patient is having acute pain, then acute pain related differentials. If patient is having some chronic issue, then chronic issue related differentials. Okay, don't take haphazard history. That I'm taking history of glaucoma, but my differential diagnosis is what? Cataract. It doesn't make sense. Okay, so your history should tell two things. One thing is it should actually give evidence about your differential diagnosis or of your provisional diagnosis, and then it should rule out your important differential diagnosis. Ask about driving in all of the cases. No one is fit to drive in all of the cases of ophthalmology. So everyone in eye station cannot drive. Okay, so ask about driving. Ask about what do you do for a living, psychological impact. Okay, ask about these things in all of the cases. Ask about pets in all of the cases in which the patient is having this blurring of vision for a longer period of time. Okay, more than a month. Am I clear?
Yes.
Yes. Dr. Arshi, you're the only one who's having who have energy right now. For some reason.
Yeah.
Which drug you have? I have no idea.
I have a question.
Yes, please.
Does it mean that in all the cases, eye cases, you have to inform DVLA?
Yes, as I mentioned that no one can drive. Okay, so in the cases in which like glaucoma cases, age-related macular degeneration, okay, these patients and retinal detachment patients, they have to inform DVLA. But for the rest of the cases, for example, in your conjunctivitis, these are infections. Any infectious related conditions, they don't have to inform DVLA because the infection will settle in few days. So they don't have anything to be worried about. But any condition which is going to last longer or it might need surgery for as treatment option, in those cases, they have to inform DVLA. Okay, and no driving for
Okay.
all of the patients.
Okay. What about in case where the patient
And not
refuses to?
autosnapsing. Sorry.
The patient refuses to inform DVLA, like in the case of diabetic retinopathy or retinal detachment. The patient
Okay.
refuses to inform DVLA. What do you do?
Okay, so in these cases, you have to tell it's patient's job, honestly. It's not your job to tell the DVLA. Okay, first you need to diagnose the condition as well, right? So he has to get themselves checked through by ophthalmologist. If he has already been examined by ophthalmologist and the diagnosis is certain, then you are in position to tell the DVLA. Okay, until
Okay.
that point, since you are not only you can just give information that you have to inform DVLA, that's fine. Okay, and patient don't really refuse to tell this to DVLA. They can insist that doctor, I can drive, and you have to convince them not to drive. Okay, because they're not just risking their life, they are also putting other people's life at risk as well if they're driving, right? So you can convince them in this manner that it's not just about you, it's about other people who are on the streets. Okay, so we have to protect the community as well.
Okay. Yes, I have one more question.
Yes.
For instance, let me take for instance the case of glaucoma, and you are in the GP setting. GP setting, you see a patient that has features of the glaucoma. Can you commence treatment at GP level, or you refer to the ophthalmologist to make diagnosis and treat?
You
What
have
can
to
you do at
send
the
this
GP
patient to
level?
the hospital immediately. That's an immediate referral.
Okay.
Okay. That's their diagnosis, and that's immediate referral. Most of the patients with glaucoma, they come in A&E, so you have to admit the patients.
Okay. Okay, but what about in case of conjunctivitis?
Conjunctivitis is,
can you manage at the level of
conjunctivitis,
GP?
nothing to be worried of.
Okay.
Viral in cases of conjunctivitis, mostly these are allergic conjunctivitis with just sedus or watery discharge. So there is no treatment required. Okay, it's just conservative treatment. Have good eye hygiene, and as I mentioned, clean the eye properly. Okay. If the patient is having allergic conjunctivitis, you can ask this patient to get topical mast cell stabilizers or topical antihistamines.
Okay.
Okay. This is GP diagnosis. This is not of the specialist diagnosis.
Okay. Just to get something clear in a clear perspective. So, so what that means is it's only cases where you need to refer to the ophthalmologist to confirm diagnosis that the ophthalmologist have to treat, right?
Okay. Glaucoma is referral.
Okay.
Cataract, refer the patient, but not an urgent referral. Age-related macular degeneration, refer the patient. Diabetic retinopathy, refer the patient. Retinal detachment, refer the patient. Toxoplasmosis, refer the patient. Scleritis, refer the patient. Okay.
Okay. Okay. Thank you.
And subconjunctival hemorrhage, you can treat it because there's no treatment. Episcleritis, you can treat it because there's no treatment. So any patient who don't need any treatment, you're going to treat it.
Okay. Okay.
Basically, you're not going to do anything.
Okay.
Okay.
And
it's always safer in eye-related cases. It's always safer to involve the specialist or this seniors. Okay.
Okay.
because the vision is at risk. Okay, so now we are going to discuss some ear-related cases. Now, this ear-related cases, it can present in three forms. First is a patient is having ear pain. Second thing is the patient is having any dizziness. And third thing is that patient is having any ringing sensation. Okay, fourth is hearing loss actually. So ringing sensation, any hearing loss, dizziness, or ear pain. Okay, please write down, you can write down the topics that we are going to discuss. Otitis media, malignant otitis externa, earwax, cholestoma, acoustic neuroma, benign paroxysmal positional vertigo, Meniere's disease. Who will repeat these things I just mentioned?
Otitis media, malignant otitis
Mhm.
externa, earwax, cholestoma, acoustic neuroma, BPPV, and Meniere's disease.
Yes. Okay. So, first thing is pain. Patient has presented with ear pain. What are the different differentials of ear pain? Patient is either having infection, patient is having wax, or patient has any trauma. So, three common differentials of pain are: one is
Infection,
infection, second,
trauma,
patient is having ear pain, trauma,
wax.
wax. Okay. So, first thing is ear pain. Now, for the infection, what are the questions that you can ask? Fever, okay, because you're discussing the infection. First thing is fever, discharge, any redness, any swelling, okay, any nose or throat related condition, or any discharge from nose, or any sore throat, or any discharge from the nose, okay, any flu-like illness recently, okay, or any water-related activity. This is for otitis externa, okay. So for the infections, what are the questions that you can ask?
Fever, any discharge from the ear, any discharge from the nose, any sore throat,
Any swelling or any flu-like illness, any water-related activity for otitis externa. For wax, along with this ear pain, do you have any loss of hearing, or do you have any hearing loss? Okay. Then second thing is any water-related activity. So water-related activity is also important in otitis externa as well as wax. Third thing, or third differential of ear pain, is trauma. Okay. So any patient, for example, any patient is, for example, it's a 40-year-old man who is presented to you in OPD. John Smith patient presented to you in OPD with ear pain. First thing is, what is the first thing that you're going to ask? Yeah, we discussed this in eye-related cases as well. What's the first question?
which ear? What about the other?
Which ear? Okay, which ear? What about the other ear? Okay, for how long have you been having this condition? And then, since it's ear pain, ask about the Socrates: site, onset, character, radiation. Anything makes it better, anything makes it worse? Have you done anything regarding it? Any associated? Now, in this association, first differential is infection, so ask infection related questions. Second differential was the wax, ask wax related questions that we discussed. And then third differential is your trauma. Okay, once you're done with this, beam of Thosa, DESA, how has this affected your life? Okay, eyes. Okay, now in your PLAB we have two sets of otitis media questions. Okay, it can present as otitis media in adults, and it can present as otitis media in children. Okay, for you to give antibiotics, it is really important that patient has any discharge. If patient has any discharge, regardless of any duration, you're going to give antibiotics. If the patient has no discharge, but the symptoms are or for 4 days or more than 4 days, you are going to give antibiotics. And for children who are less than 2 years and they have bilateral otitis media, in those kids, you are going to give antibiotics. So what are the three indications of antibiotics? First is
If discharge with otitis
discharge.
media duration, then more than equal to 4 days of the condition. And third is bilateral otitis media in children.
Bilateral otitis media in children and children who are less than 2 years. Okay, less than 2 years and bilateral. Okay, so first thing is take the whole history as we discussed in your management. If the patient see, whenever the medication for any disease is penicillin, please ask for the allergies, because if the medication is is penicillin, they will tell you that doctor, I'm allergic to penicillin. So please ask the allergy. That's a must. Okay. On your otoscopy, what you can find in otitis media case is inflammation or redness of tympanic membrane. Okay, they can give you fever in the vitals as well. Okay, since again this is an ear examination, please ask for the chaperone as well. Okay, now what the patient is having, thank you so much for answering my questions, and thank you so much for examination. What you are having is what we call acute otitis media. Acute otitis media means that there is infection of your middle ear. Okay. Now, the next monologue depends on whether the patient is having a discharge or not, or whether the patient is having this ear pain for more or equals to 5 days or 4 days or not. Okay. So if the patient is only having symptom for 1 day, then okay, most likely the the reason for this acute otitis media is viral infection. So it will settle on its own. What you can do is you can just take paracetamol, over-the-counter paracetamol for pain and fever. Take rest, keep yourself hydrated. And if your symptoms are not improving, even after 4 days, please come back to us and we'll give you antibiotics. Second case is in which the patient is having this ear complaints or ear pain for 5 days. In those patients, you are going to give antibiotics. The antibiotic of choice in acute otitis media is penicillin. If patient is allergic to penicillin, the second line of medication is clarithromycin. Okay, he can take clarithromycin for 5 to 7 days. Rest of the things, it's same. Keep yourself hydrated. Take paracetamol for fever and pain. Okay, there's no follow-up required. Okay, and you can do safety netting as well. Okay. In children, mostly the children are mostly in children related cases, those are not less than 2 years, and those do not have bilateral otitis media, so there's no need to give antibiotics. Okay, but the mother will insist that doctor, please give me antibiotics. I can give my child after 2 days or after 3 days, so the total will be of 4 days. Or if my child has any discharge, I'll give it to my son or my daughter. Please, even if she cries in the cubicle, don't give her antibiotics. Okay, don't give her antihistamines as sedation, because she can say, the doctor, my child is not sleeping because of the pain. Okay, so if there is no discharge, okay, and child is just having this ear pain for less than 4 days, no need to give any antibiotics. Okay, tell this to the mother that this is highly likely a viral infection, and she will counterattack that, doctor, the pain is getting worse day by day. So tell her that the viral, basically, this is how viral infection works. Okay, initially the patient, when it's the start of infection, they don't feel that much pain, and then they reach to then the pain gets worse, and after that time the pain will get settled. So initially not so much pain, then the pain will get worse, and then it will get settled. So before it gets settled, it will go worse. Okay, you can take over-the-counter Calpol, keep him hydrated. Okay, and there is no need to give antibiotics. Okay, and there is no need for sedation as well. Am I clear? Am I clear?
Yes.
Now, this is acute otitis media cases, but there is one patient who can present like in another way, that doctor, my son, he was having some pain in the ear for a month. Okay, but after some time, after a week of this pain, The pain got settled, but since that time, he's been having discharge from the ear. For last 3 weeks, I'm seeing this discharge on the pillow. What could be the diagnosis, doctor? Patient was initially having pain, then pain gets better, but patient is having discharge for 3 weeks.
So there's a ruptured tympanic membrane. That's
Yes, there's a perforation of tympanic membrane, okay, or perforation of eardrum, okay. Is there anything to be worried about here?
usually heals on its own.
Yes, it heals on its own, so there is nothing to be worried about, or there is no treatment required. But still, we are going to refer your child to the hospital immediately because we want seniors to see it, okay, or the specialists to see it, and they might take swab, okay, and if there is any infection still, they will give him some antibiotics, okay, and they will do some ear washing, toileting, and cleaning, okay. The antibiotics, it will depend on the infection. Okay, if there is infection, they can give the antibiotics. Usually there is no need for the surgery, but if the pain is getting, if the, if the perforation is not getting better, they can go for tympanoplasty. Am I clear?
How long do we have to wait for
Usually it gets settled for in 6 weeks,
okay.
sometimes 6 months as well. It takes some time, but there's nothing to be worried about.
Do we need to give the patient a specific time frame?
We don't.
Okay.
Okay, you can say in months because it gets better in months.
Okay.
Okay. Now, these are ear pain related cases. Okay, this is acute otitis media. We'll discuss about otitis externa later in the presentation. Now, the second type of cases is earwax. Now, earwax presents with ear pain along with some hearing loss. In acute otitis media, there is no hearing loss, but in this case, in earwax cases, there is some hearing loss as well. Okay, the patient can give you a history of water-related activities. Okay, swimming, he can give you a history that, doctor, I went for swimming, or I had a travel history and we had some water-related activities. Okay, so take that history. Also ask him that, do you clean your ear? Do you clean your ear by these cotton buds or not? Okay, why this question is important?
Because when we clean the ear using cotton buds, it pushes the wax even further inside and causes it to get
Yes,
impacted.
yes. Okay, this is what happens. So in these cases, if the patient is having ear pain along with some hearing issue, and on your examination you find some earwax in the mannequin, then the diagnosis is certain that this is earwax. So what is earwax? So from what you have told me, there is wax in your ear, which is collection of dead cells and oily secretions. Okay, Mr. John, or whatever his name is, the ear has self-cleaning system, okay, which basically protects the ear, okay, and it cleans on its own, so you don't need to actually clean it from with the cotton bud. Okay, so if this patient mentions that, doctor, I used any earbud, say that, since you use the earbud, it has pushed the wax further into the ear, and that's why you're experiencing pain. If there is no such history and patient saying that, doctor, I had some water related activity, or I went for swimming, you can say that, whenever you go for swimming, whenever the wax, it comes in contact with the water, it swells up, okay, and it can cause ear pain. Okay, so right now what we are going to do for you is we are going to give you some ear wax softeners. Okay, these can be oil-based softeners, or it can be sodium bicarbonate. Okay, so you have to apply these softeners for 3 weeks, twice daily, 3 drops. 3 drops a day, 3 drops twice daily for 3 weeks. Twice daily, 3 drops for 3 weeks. Okay. After 3 weeks, if even after 3 weeks, if the wax is not wax is still there, or the symptoms are not getting better, then we can go for irrigation. If this patient asks you, the doctor, can I just go for irrigation? Say that, it is not routinely practiced. And even if you go for irrigation, you need to use these wax softeners first and then go for irrigation. Okay. Also, this irrigation is not funded by NHS. So even if you have to do it, you want to do it, please go to private clinics. Okay, this is not funded by NHS. So that's one case in which the ear wax is there. Okay, you saw it in the mannequin. Okay, and that's how you are giving the treatment. But there is another case of ear wax in which patient is a follow-up case, where in which the patient has follow. Okay, two cases of follow-up of ear wax. In one case, the patient presented 1 week ago because of some ear wax. Okay, your colleague actually gave some drops to the patient. Okay, because he couldn't visualize the eardrum. Okay, but still he gave the drops. Now, when you visualize the eardrum, patient is still having the same complaints. There is wax. Okay. Now, since this patient only used this ear wax softeners or these softeners for only just 1 week, please ask the patient to continue the same medication for 2 more weeks, and if not better, then irrigation. Okay. This patient will have same complaints. Doctor, I have ear pain or I have some hearing issue. Okay. But there is one more case of earwax in which the patient initially presented with earwax. All right. You gave some softeners. Okay. Patient took the medication. And after a few weeks, he came back and now the patient is still having hearing loss. But you cannot see any wax in the mannequin. That means that now the reason of this hearing loss is not the wax. So it has to be something else. So we need to check this. Okay, and we are worried about these things. All right. So in this case, you have to refer this patient to specialist. Okay, to ENT specialist. He will do the audiometry. He will do the hearing test as well, and he might go for MRI as well. Okay, to rule out any serious condition or any serious nerve related condition. Okay. So, am I clear so far regarding this earwax related cases? And you guys got the idea about different. Yes.
And with this last scenario you just painted now, what about because you mentioned that you checked the ear, you didn't see earwax, you probably refer to do other ear tests like audiometry and so. Now, in the case where you are not too sure of what you are seeing, what will you do?
Okay, so if the eardrum is, even if you cannot see anything, okay, and there are two things, right? One thing is that when you're doing otoscopy, there is absolutely nothing in the eardrum. It's extremely clear. That means that there is no wax, and you need to send this patient to the hospital. If you're not sure about this condition and you think that there is something, then continue the medication. If you feel that there is something, please continue the medication. But if the eardrum is extremely clear, that means that there is no wax. Send this patient to the hospital. But for this reason, you need to take the proper history and you need to do the otoscopy right as well. Okay?
Okay.
Because in these cases, you actually need to know what's going on in the head and the ear. Okay? Because this is referral. So, in this case, since the patient is not experiencing any other complaints other than the hearing loss and the fact that he was initially having the earwax, you're not really sure about the acoustic neuroma, so don't say that it's acoustic neuroma. Okay, don't say this word acoustic neuroma. Okay, just say that you're having this acute sensory neural hearing loss, and because we are worried that the hearing loss is whether it's coming from your nerves or not. So that's why we're going to refer you to the specialist. Okay. And the ENT specialist, he will do the audiometry and he'll do an MRI. Right? Now, the next case is of acoustic neuroma. Acoustic neuroma patient usually presents with what? DVT, deafness, vertigo, tinnitus, along with facial nerve palsy or balance issues. So nerve, your 7th nerve, 8th nerve, and sometimes 5th nerve as well. Okay, defect in those nerves along with deafness, vertigo, tinnitus. Okay, so there must be some hearing loss as well. This patient will give you some family history as well of some skin-related condition or any hearing-related conditions. All right. The diagnosis is the same. The management is the same as we discussed previously. Okay, in the sensory neurodiagnosis. So what is this condition? This is acoustic neuroma. Acoustic neuroma means that there is a growth in the nerves responsible for your hearing and balance. So what we are going to do for you is we are going to refer you to specialist or ENT specialist. Okay, he is going to perform audiometry and he is going to check to do MRI to rule out other causes. Okay, if it is confirmed, the treatment is highly likely surgery. Okay. In ear wax cases and acoustic neuroma cases, please tell the patient that he cannot drive. Okay. So now we have two cases left, which is cholestoma and the last one is external otitis media. So this patient with the cholestoma, what is anyone who's aware of cholestoma? What is cholestoma? What is cholestoma?
I think
Doctors, what is
it's collection.
cholestoma?
It's collection of abnormal epithelial cells and I think it also contains cholesterol pigments within the middle ear.
Okay, so it's basically collection or growth of the skin inside the ear. Okay, which basically it is damaging its nearby structures. Collection or growth of the skin inside the ear, which is damaging other ear structures. That is what we call cholestoma. So usually this cholestoma patient, this is old age patients with some discharge in the ear. Okay. Whenever the patient comes with the discharge, ask about whether there is any blood in the discharge or not. What color is it? Is it clear? Okay. How much discharge is it? Mostly it's clear in color. Okay. Whether the discharge is smelly or not. Okay. Since this patient presents with discharge, your differential is again trauma, some infection. So take those differentials and ask questions. Okay. What is this condition? This is cholestoma. It is collection or growth of skin inside the ear. Okay. And now it is damaging other structures. That's why you're having these symptoms. So we are worried about you and we are going to refer you to specialist or ENT specialist or we are going to admit you and we are going to invite the specialist today. Okay. They are going to perform some hearing tests, some audiometry, MRI. Okay, they will take a swab of this discharge, okay, and they will send it to the lab and see if there is any active infection or not. Okay, they will do ear washing and ear toileting. Okay, and after that, they will give you some medications to reduce this inflammation. All right, and if it is confirmed, then the treatment highly likely is surgery to remove the skin, basically. Skin on this growth. Avoid driving. Okay. The last case is malignant otitis externa. Now, malignant otitis externa, usually otitis externa is not so much of a big deal. But malignant otitis externa is basically a patient who, mostly these are female patients and these are immunocompromised patients, okay, who are maybe diabetic or who have some autoimmune conditions for which they're taking steroids, okay. Along with the ear pain, they have hearing loss, okay. And, this thing has affected their life so much. They will tell you that it has affected their life. Maybe she is a piano teacher and she cannot teach because of this hearing loss. Okay. So pain and hearing loss along with some autoimmune condition for which they're taking some steroids or methotrexate, or patient who is diabetic, basically who is immunocompromised. Okay. So For this patient, again, this is what is otitis externa? What is otitis externa?
It's infection
In-
of the external ear
External
compartment.
ear. Yeah. So
Yes,
this
which
is okay. This is otitis externa, which is infection of the outer aspect of the ear. Okay. Mostly this happens in the patients who have low immune system. Since you mentioned that you have this condition, whatever condition he is having or she is having, since you have this condition and you're taking this medication, it puts you on risk of developing this condition. We are going to keep you in the hospital. If this is GP, send this patient to the hospital. If you are in emergency department, please keep him in the hospital or keep her in the hospital. Okay. The specialist will come and they will re-examine this patient, take the swab, do other type of blood tests and offer antibiotics. Mostly the antibiotics in acute malignant otitis externa, it is ciprofloxacin. Okay, so antibiotics of choices, ciprofloxacin. Okay, and we will wait for the blood results, and the rest of the management will depend on your blood infection, your blood results and infection. Okay, if it's severe, then we are going to keep you in the hospital for longer period of time. Okay. So any patient with eye pain, red eye pain with history of RA, what's the diagnosis? Red eye.
Please come again.
Patient with red eye, painful red eye basically, and with the history of RA, rheumatoid arthritis. What's the diagnosis?
Scleritis.
Yes, good. So this is clincher for scleritis. Now, patient with pain, hearing loss, along with rheumatoid arthritis or RA or diabetes mellitus, this is malignant otitis externa. Both needs autoimmune diseases. Both needs immunocompromised patients to work. Okay, and that one patient, toxoplasmosis patient, they can also present with these kind of things. They are also immunocompromised. So now these are some ear-related conditions. Now we have some dizziness-related cases as well. Are you guys familiar with those cases? Benign paroxysmal positional vertigo, Meniere's disease. Guys, are you guys familiar with those cases, or I should discuss those cases?
You can just discuss like the main points, maybe, like what to ask. Just the main points.
Just write one mnemonic then. DVT. DVT, fullness. Just write one mnemonic and then I'll discuss. Done?
Yes.
Yes. So, what are the causes of dizziness? Patient is saying, doctor, I feel dizzy. What are the causes of dizziness? Other than ear-related conditions, what could be the cause of dizziness?
Hypoglycemia.
Hypoglycemia. Okay.
It could be BP fluctuations like postural hypotension.
Good.
Then it could be a stroke as well.
Yes. So, first ones are your ear-related conditions, your vestibular neuritis, EPPV, Meniere's disease. Other conditions are stroke, CVS issues, or anemia, right? So, please write these 5 differentials. Patient with dizziness. First is vestibular neuritis. Second is BPPEV, benign proximal positional vertigo. Third is Meniere's disease, then stroke, then CVS, then anemia. Now, in front of vestibular neuritis, please write patient with recent flu-like illness history, generally unwell patient with frequent attacks and vomiting, and attacks which last for weeks. Am I clear? Am I
Yeah.
clear? Okay. Now, in front of benign paroxysmal positional vertigo, right? Change in position, deafness, vertigo or dizziness when changing position, recurrent, and attack lasts for seconds to minutes. Third one was Meniere's disease. Deafness, tinnitus, vertigo, along with the fullness in the ear. And attack lasts for minutes to hours. Stroke, any weakness in any part of the body. CVS, any palpitation. Anemia, tiredness. Am I clear?
Yes.
Yes.
So these are all the differentials of your vertigo along with the dizziness. Okay. So in all of the patients, after you're done with the 4D para, okay, you are going to ask these questions. Okay, these are 5 most important differentials that you have to ask in all of the patients. Okay, and these are some typical findings that you will, once you're done with the 4D para and you have asked the differential, you will get the diagnosis, even in the first 2 minutes of your history. Am I clear?
Yes.
Yes.
Okay. In your examination, you are going to do you are going to check vitals. Then you can do some balance tests. You can do Dix-Hallpike maneuver.
Do we actually need to do the maneuver or just verbalize it?
Just mention it.
Okay.
You don't have that much time. Vitals, ENT examination, nerves of head and neck, Dix-Hallpike maneuver or Dix-Hallpike test. So now the first patient is an old age patient or middle age patient who presented with dizziness, and he's having dizziness for a week, which lasts for a few seconds to minutes. What is the diagnosis?
BPPV.
BPPV. Okay. So one typical finding that you will find in the history.
The dizziness sets in whenever they change their position, like head position.
Good. Okay. So tell this to the patient. Now you're moving towards your management. Okay. What is the management? First comes the definition. So you're having a condition called benign paroxysmal positional vertigo. Okay. This is a condition of the inner ear. Okay. In which basically patient experiences repetitive episodes of sensation of spinning for a shorter period of time. This can last from seconds to minutes. This is called benign because there is nothing to be worried about. Usually it resolves on its own, so you don't need to do anything. Okay, but there are certain things, or there is certain advice that you can follow. Okay, please avoid any sudden neck movements. Avoid any quick movements. Don't overstretch your neck muscles. When you wake up in the morning, please sit on the edge of the bed for a while, okay, and then get up. Okay. So whenever you are experiencing this attack, please make sure to sit down. Don't panic. Look around and just fix your eyes on one single or one focused object. Okay. And sit there till the attack resolves. drink plenty of water, okay, and you'll be fine. Do exercise, and if the patient is not getting better, okay, you can go for Epley's maneuver as well. You can make follow-up with this patient for 4 weeks. One important thing in this patient that you can find is the patient is working as a scaffolder. Okay, scaffolder means that these people are working at heights, so he needs to change his job. So okay, so ask this patient to change his job because it can put his life on risk, because if he is at certain level or he is at certain height, and if he had this attack and he falls, it can take his life or it can put his life in danger. So change your job, okay, or just ask your employer to change the nature of your job or give you a desk job. Okay, if the employer is not giving you any other position, then go to job centers and find another job. Right?
All right.
Now, the next thing is vestibular neuritis. Now, these patients are usually generally unwell patients who are having these attacks very frequently, and for weeks they're having these things. Okay, and they are feeling they had recent flu-like illness. This is vestibular neuritis. Okay, now what is vestibular neuritis? It is inflammation of the nerves which are responsible for hearing and balance. Okay, so you have to ask these patients that whether they can eat or drink or not. Okay, if they cannot eat or drink, then you have to keep them in the hospital. Okay, and that also changes the course of how they are going to get the medications. Okay, if the patient cannot eat or drink, then you have to give IV. Okay. So what we are going to do for these patients, keep them in the hospital, give them medications. Mostly these patients cannot eat or drink, so we'll give the medications through the veins. Okay, and after some time, when they will be able to take the medications through their mouth, we can change it to the oral route. Okay, we are going to offer these patients some antihistamines for 3 days, which is chlorpromazine. Okay, chlorpromazine or cyclizine, just for 3 days, not more than that, no, not less than that. Okay, drink a lot of fluid once this patient is discharged. Okay, then you can make the follow-up with this patient after 6 weeks. Okay, even after 6 weeks, if the patient says that, doctor, I still have these attacks and this is not getting this is not getting better, then you're going to refer this patient to vestibular rehabilitation centers. Okay, these are basically just the departments which are going to guide this patient how to deal with these symptoms. That's it. So your treatment is antihistamine, chlorpromazine for 3 days. Okay. The next one is Meniere's disease. What was the signs and symptoms of Meniere's disease?
EVT.
EVT along with
Your fullness.
facial fullness. Okay. In this case, when you are going to do some hearing test, since the patient is not having any attack right now, the examination would be normal. Okay. Mostly the changes in examination occurs when patient is having attack. Okay. So when the patient is sitting next to you and his examination is normal, but he's saying that I'm not having attack right now, then that makes sense. Okay? He won't be having any abnormal symptoms, abnormal findings if there is no active attack. Okay. Dix-Hallpike is normal in this case, and Dix-Hallpike is positive in which case Dix-Hallpike is positive?
EPPAB.
Yes. Now, what is Meniere's disease? Doctors, Meniere's disease is a disease of inner ear, middle ear, or outer ear, external ear.
Inner ear.
Inner ear. Okay, so basically, you're having a condition called Meniere's disease. Okay, which is a condition inner ear.
Inner ear.
Okay, in our inner ear, we have small tubes. Okay, and these tubes are filled with water, not water, fluid. Sorry. These tubes are filled with fluid, which helps you in balance. Sometimes, due to some reason, these tubes can be affected and it can cause dizziness. Okay. So what we are going to do for you is we are going to refer you to ENT specialist, and they are going to perform some audiometry, some MRI, okay, because they want to rule out some other nerve related conditions. Okay. For symptomatic treatment, you can give this patient chlorpromazine, and this is for the acute symptoms. To decrease the frequency of these attacks, you can give this patient beta histidine. Okay. Do not try, inform DVLA, and make follow-up with this patient in a week. Okay. Regarding your other dizziness cases, stroke, I think you have covered this already in your neuro cases. CVS is just, these are just your differentials. You don't have to go through this, okay? And anemia. Okay. These you must have covered in rest of your classes. Okay. So these are some eye-related conditions and some ear-related conditions. Now, can someone please tell me, have you guys covered the follow-up of hypertension? A patient who's taking medications for hypertension, have you guys covered the follow-ups for those cases?
I mean, in the counseling stations, Dr. Hasna, she just mentioned that if a patient is a known case of hypertension, he comes for a follow-up and he has cough. So just
He
that.
has cough. So you have covered those things. I'm just going to share my screen. Can you please tell me, have you guys covered these things or not? Okay. This one. You have covered this one?
Yeah, she did discuss this case.
Okay. This one?
No.
No? Okay. So, and you guys know how to take the history in follow-up cases?
It was actually part of the counseling scenario. So,
okay. So basically, how do we take history of follow-up cases? So in these cases, you already know the diagnosis, okay? And you're aware what patient is having. Patient is also aware what he's having, okay? And the treatment he's getting. So first thing is, as we understand that you came here because you are having this condition, okay? What do you know about this condition? Okay, what what have you done regarding it? Okay, what treatment are you getting, and are you complying to the medications or not? Then signs and symptoms. Signs and symptoms. First thing is any current complaint, okay, or any current sign and symptom. Second thing is the complaints which are associated to the disease itself, and then the signs and symptoms which are associated with the complications of the disease. First thing is understanding of the disease, understanding of the condition or disease, diagnosis, and treatment. Then any present complaint, then side effect or complication of the disease, side effect of the medications, theme of TOSA, and then you have to fix the issue. This is how you take the history of the follow-up cases. For this one, as you have already discussed this hypertension case, we're going to move forward towards this polymyalgia rheumatica case. So in this case, patient has already been diagnosed with PMR, which is polymyalgia rheumatica. Okay, for polymyalgia rheumatica, patients are usually on steroid. Okay, and they came for the follow-up. Okay, so in this case, they can give you ESR findings. Okay, it's written outside the cubicle that ESR is done, ESR levels are done, and they are either improved or they are same. Okay, so you have to deal according to that. You have to take action according to those ESR levels. If the patient is presenting to you with EMR and they say that ESR levels initially they were 50 and now ESR levels are 15, that means that patient's health is improving. If they're saying that initially the PMI, the ESR levels was 50, and now it's 49, then that means it's pretty much the same. Okay, so that is your first thing. Check the ESR levels. Okay, because that is going to indicate whether you are going to change the medication, or you are going to change the dose of the medication or not. Second thing is associated complaints. Whenever a patient is taking steroid, they cause gastric issues. Okay, so patient can present with some sort of gastric issues. And others think that steroids they cause osteoporosis, so they cause bone pains. So along with that, you are going to give this patient lansoprazole for the gastric ulcer and alderanoic acid for osteoporosis. Am I clear so far?
Yes.
Okay, so if now we're talking about the two cases. In first case, patient presented to you with it's written outside the cubicle that 40-year-old John, he presented to the OPD 4 weeks ago. And he's diagnosed with PMR. He's given steroid treatment. He is taking 15 mg of steroid. 3 weeks, recently, 3 weeks ago, the ESR levels were 50. Now ESR levels are 15. Okay, patient is having some concerns. First thing when you're taking the history is, okay, as we understand, Mr. John, that you have been diagnosed with a condition, polymyalgia rheumatica. What do you know about this condition? Okay, so, can you please tell me what initially happened, how you got diagnosed with this condition? Which investigations they performed to diagnose this condition? Okay, which treatment they are giving you for this disease? Okay, are you compliant with the medication? First thing is understanding why you developed this, how you got diagnosed with this condition, which investigations they perform, which treatment they're giving you. Okay, so understanding is done. Second thing is any complaint, any active complaints. Okay, as we understand that you have this condition, can you please tell me how are you feeling? Do you have any active issue? PMR is basically joint pain, right? So can you please tell me a little bit about your joint pain? Is your joint pain getting better or worse? Okay, do you have any other complaint? Okay, so just little bit about any current history or a current active complaint. If he's not giving you any, it's fine. Okay. Now, second thing is complication of the disease or complication of the disease. What is the complication of PMR? Doctor, what is the most important complication of PMR?
Giant cell arteritis.
Giant cell arteritis, and it is association. What's another thing? In giant cell arteritis, what is the common association? Give me signs and symptoms.
Loss of vision.
Loss of vision, okay? So headaches, loss of vision. Then after this complication of the disease, you're going to ask the complications of the medication. The medication in the case of PMR is steroid. Steroid can change blood sugar levels. It can change, it can basically increase your blood pressure as well. It can cause gastric ulcers, so heartburn. It can cause joint pains. Okay, it can make your bone fragile, so it can cause joint pains as well. Okay. So ask about the complications of steroid, okay, and any recent weight gain as well, okay, and insomnia, weight gain. Have you checked your blood sugar levels recently? Any fluctuation in that? Do you feel that have you checked your blood pressure recently? Any change in that? Okay. Do you have any gastric issues, or do you have any heartburn? Okay, or do you have any joint pains? Okay. Once you've taken the history, since in the start we discussed that initially the ESR levels were high and now the ESR levels are low. Okay, so in your exam, after you're done with the examination is basically focused on the disease itself. So if the patient was having initial pain in the shoulder and hip, just examine those joints, check the vitals, and check the sugar levels. That's it. So, Mr. John, as we understand, you have been diagnosed with a condition called polymyalgia rheumatica. Polymyalgia rheumatica is an autoimmune disease, which means that the body is attacking its own cells. Okay, and basically it is an inflammation of your muscles and the bones surrounding it. All right. As we understand that you were given some steroids 3 weeks ago, and we have the blood levels we have the inflammatory markers with me. I have the inflammatory marker result with me, and fortunately, the inflammatory markers they have improved. That means that the medication is working. So what we are going to do for you is we are going to decrease the dose of the medication only if the ESR levels are improved. Okay, so initially, if the this medication was 15 mg, you can decrease the dose to 12.5 mg per day. Okay, so you can decrease the dose of your steroid. Okay, along with that, as when patient is taking steroid for longer period of time, it can cause gastric issues. It can cause gastric ulcers. For that, we are going to give you medication called lansoprazole. Okay, you have to take it before meal. Okay, since this patient would be old age, so as we understand that with age, advancing age, the bones becomes weak. Okay, and steroid it also makes the bone fragile. So what we are going to give you, what we are going to offer you is alginoic acid. Basically, you have to take this medication empty stomach. So there are two composition of this medicines. Either the patient can take 70 mg per day, 70 mg per week, or 10 mg per day. Okay, so either. So you have to take this medication early morning. Okay, empty stomach. Please sit upright when you're taking this medication and keep on sitting for at least 30 minutes. And after 30 minutes, have your meal, have your breakfast. Okay, we are also going to give you blue steroid card. So whenever you go to any pharmacy, you have to tell them that you are taking steroids. Okay, that's the first variation. If the patient is here and he is not, the ESR levels are not improved, just cut those lines in which you are saying that, okay, ESR levels are improved, so that's why we are decreasing the dose. If the ESR levels are not improving, just say that, we check the ESR levels, and unfortunately, that ESR levels have not improved. Okay? So that means that you have to continue the same dose of the medication. Am I clear? And safety net for blindness. Am I clear?
Yes.
Yes.
Okay. So the next follow-up cases is epilepsy. Okay, so it can come in different variations. Okay, so it can come in different variation. First, in first variation, patient was diagnosed with epilepsy. Okay, he was provided with sodium valproate 600 mg PD. Okay, and the patient recently developed a fit. Okay, so now first thing is how you were diagnosed with. You got diagnosed with this epilepsy. Which investigations they perform and what treatment are you getting? Are you compliant with the medication? This is extremely important question. Are you compliant with the medication? Okay. Once you're done with this thing, ask rest of the questions. Okay. When was your last fit? Okay. And then if there is any fit, take the before, during, and after history of the fit. What is before, during, and after of the fit? Who will tell me before, during, and after of the fit?
Any weakness of the body, any heart racing, sweating.
That's before or after or during? What?
Like we can just start
I think
asking what were you doing when this happened?
Okay.
Were you experiencing any
yeah.
Then
And then during is did you lose consciousness and did you hit your head?
yes, and
And then after is when did you regain the consciousness and were you drowsy after?
and Post-tussive vomiting.
Yeah, vomiting and any ENT bleed.
Okay, any bleed, any vomiting, any incontinence of urine or stool. Okay. So these are some questions that you have to ask regarding before, during, and after of the fall. Okay. Then, since this patient was diagnosed, see that now the rest of the history depends on when the patient was diagnosed with this epilepsy. If the patient was diagnosed with epilepsy for some years, you can ask about the effect of this epilepsy on his day-to-day activities. Okay, and you have to ask some of the risk factors. You have to take the history of some of the risk factors which can precipitate the epilepsy attack. What are some some things which can precipitate the epilepsy attack?
Lights.
Lights, okay, bright lights,
No
loud music.
loud
What
music.
are his hobbies? Okay, sometimes if the patient is having hobbies like hiking and swimming and everything, it can precipitate an attack. These things itself, they don't precipitate attack, but what these things do, they exhaust people. Okay, and it puts the body under pressure. Okay, and the patient might have an attack because of that. Okay, so take the history about those conditions. Am I clear?
Yes.
Okay, so now we're done with this thing, complications of the disease, and then complications of the medication. What is the complication of the medication? Sodium valproate. What are the complications of the sodium valproate? Any side effect of the medication that you are aware of?
Nausea, vomiting.
Nausea. This is something that we used to do in mid school. Nausea, vomiting for everything. What else? Hair loss, insomnia, fatigue,
Okay.
headaches, weight gain. What are these things? Hair loss,
Nope.
insomnia, fatigue, headaches, weight gain. Okay, then this thing is done. Now the next thing is hemoptysis and the risk factors which can precipitate the attacks. Okay, take the history of skipping meals as well. Okay, and sleep hygiene. All right, and then effect of this thing on his day-to-day activities. Any concern or any specific thing that he is expecting from us today. Okay, in your examination, you have to check the vitals. You have to do the head and neck examination as well. Okay, now tell this patient. Now we have variety of patients. First thing is the patient is taking sodium valproate for longer period of time. Okay, and because he was not taking the medications properly, that's why he's having this attack. That's your first case. Second case is in which the patient is patient has just been diagnosed with this attack, this epilepsy. Okay, and you have to tell him that he's having idiopathic epilepsy and he has to take these medications. Okay, and third one is in which you are talking to the mother of the child who was diagnosed with epilepsy, and you just have to counsel her regarding that. Okay, so regarding the first case, tell this to the patient that thank you so much for answering my questions. So basically, you're having as we understand, you're having a condition called epilepsy. Okay, epilepsy is basically a medical condition in which there is abnormal activity in the brain which causes fit. Okay, since we don't know the cause, that's why it is called idiopathic epilepsy. Okay, unfortunately, it's a lifelong disease, so you have to take medications every single day. Okay, and not when you develop a fit. Okay, so this is a lifelong disease. That means that you have to take this medication lifelong. Okay, and not only when you develop fit. Okay, why? Because it is important for you that certain amount of medication should always be present in the body all the time. Certain amount of medication should be present in the blood all the time. Okay. Since you have been prescribed sodium valproate 600 mg BD, that means that you have to take it twice daily, 2 times a day. Okay. Also, since you have epilepsy, I'm afraid that there are certain things that you cannot do. Okay, or there are certain things which can make your condition worse or which can trigger your attack, like stress, drinking, excessive alcohol, drinking excessive alcohol or loud noise, flashy lights, lack of sleep, skipping meals. Okay, all of these things can precipitate an attack. Am I clear so far?
Yes.
Okay, so now this is since this patient for these kind of patients, you have to ask about their travel history and you have to ask about their hobbies as well. Okay, because this patient can tell you, the doctor, I'm going for a hike. So you have to convince this patient, please don't go to any hiking. Okay, try to convince him in the best way possible that don't go to hike, okay, or anything. But if the patient is not convinced, then tell him that, you know, at least tell someone who is going with you that you have this condition. Okay, when you're going to the when you're going for the hiking, please take short breaks, keep yourself hydrated, and eat your food. Okay, do not drain your body. Okay, or don't put so much pressure on your body. Okay, because otherwise it can precipitate an attack. Okay, so eat well, sleep well, drink well. But the best thing is, please don't go to hike. You cannot drive because for driving you have to be fit free for at least 2 years. Okay. All right. Other things that I mentioned earlier, the risk factors, please avoid those things as well. Please avoid cooking in the kitchen alone. Okay. And cut down screen time. So that's first case of epilepsy in which patient was already diagnosed with epilepsy and now he developed recent fit because he was not taking medications for it. The second case is in which the patient is recently been diagnosed with epilepsy, and this is the medication that you have to provide. You have to tell him regarding. Okay? Same history, same examination, same management. Okay. The third case is the patient in which basically the patient is a child. Okay, 6-year-old girl. Basically, she was diagnosed with this epilepsy. Okay. And basically mother wants to talk to you. So in this case, you have to inquire about the hobbies of the child from the mother. Okay, whether she likes to dance, she likes to do this swimming or anything. Okay, so you have to inquire all of these habits from the mother. Right? In that case, basically, your management remains the same. Just one thing is different, that this mother will have a lot of questions. That doctor, my daughter, she loves to dance, you know, but are you telling me that she cannot dance anymore? So no, she can dance, but avoid dancing in, under spotlight. And avoid dancing on the edge of the this stage. Okay. Keep yourself hydrated. Yeah, ask someone to be with your daughter. Okay, ask some trusted teachers or family members to be with your daughter all the time. Okay, so they can handle her situation. Now, this mother will also give you one concern, that doctor, if this is a lifelong condition, that means that I always have to be with my child. Okay, so no, she doesn't really need to go everywhere with her daughter. Okay, as long as the daughter is taking medications properly. Am I clear?
Yes.
Okay, rest of the things the same. Okay, don't stress your stress of your body and everything. One more case about epilepsy is the one patient who was fit free for some time, then he stopped taking medications, and now he developed attack again. So he cannot drive. So that's basically about the driving, that he cannot drive since he developed this fit reason. All right, rest of the things per se. Now, there is one more case in which the patient presents to you with the tiredness, okay, and it's written outside the cubicle that patient is really worried about diabetes mellitus, okay, the blood sugar levels are given, BMI is high, blood sugar levels are normal, okay, and patient has tiredness. So take the history of the tiredness, okay, and he will tell you, the doctor, I cannot fall asleep properly, and I snore at night as well, okay. So in obstructive sleep apnea, you have to take Epworth score, which means that do you fall asleep while watching your favorite movie? Do you fall asleep while driving? Do you fall asleep while reading your favorite book or while talking to someone? Okay, if yes, then this is obstructive sleep apnea. Okay. Now, what is the management of obstructive sleep apnea? You are having a condition called obstructive sleep apnea. That means that when you are sleeping, your throat muscles, they get relaxed, okay, and because of them they get over relaxed, and they basically it basically obstructs your airway. That's why you wake up in the middle of night gasping for air. What we are going to do for you is we are going to refer you to sleep clinic. They're going to perform a special test called polysomnography, in which they are going to check your vitals or your heart levels, or they are going to check the electrical activity of your heart and brain while you're sleeping. Okay. Once the diagnosis is confirmed, the first and most important thing for obstructive sleep apnea is weight loss. So first thing is, please have a good lifestyle, okay, and try to reduce your weight. Okay, it will help you to get better. Second thing is CPAP. Okay. Third thing is mandibular advancement device. But first, mainstay treatment is always weight loss. Okay, for obstructive sleep apnea. Okay. Now, the third case is chronic fatigue syndrome. Doctor, anyone who's aware of chronic fatigue syndrome? What is chronic fatigue syndrome?
It's basically unexplained tiredness for more than 6 months.
Unexplained, okay. And is it functional thing or something, some
It is
pathological?
a disorder with no cause and no treatment.
Yes, okay. So unexplained tiredness for 6 months. Okay. And patient can give you a history of some flu-like illness. Okay. This patient again came for a follow-up. Okay, he has run all the blood tests, but you don't know the results because the IT system is not working. So don't just say that IT system was not working, so that's why I don't have results with me. Ask from the patient, okay, which tests were done? Okay, because there are chances that this patient will tell you, the doctor, I haven't really gone through any of the tests because I was really busy. Okay, and then you can say, okay, but IT system is also not working, so even if you have gone through those tests, we don't have the results. Okay, but first get the idea whether he has done some tests or not. Take proper history of tiredness. Explore all the other causes of tiredness, including bone cancer, obstructive sleep apnea, thing, anemia. Okay, depression, hypothyroidism. Take all these differential history. Okay. Now, for your management, what is this condition? This is called chronic fatigue syndrome. It is a functional condition in which there is no structure abnormality, but the body is not producing enough oxygen to cope up with the demand. So what we are going to do for you is, since the patient has not undergone any of the investigations earlier, okay, so you're going to repeat the test. If the patient says that, doctor, I have done all the blood tests and your IT system is not working, don't go for the tests again. Okay, if patient has not gone through any tests, then check CBC, blood sugar levels, TFTs, vitamin profile, including vitamin D, vitamin B12. Okay. And then refer this patient to chronic fatigue clinic. Okay. So basically what happens there is they are going to assess his condition and they're going to treat his condition. Okay. And specialists, they are going to guide him how to manage the energy throughout the day. All right. So rest of things are just lifestyle advices. Okay, you can say that, you know, those the people in that specialized clinic, they can give you specialized diet chart as well. Okay, they can give you some customized exercise plans as well. Okay, so you can utilize your energy to the max. Okay, please keep yourself hydrated, eat good food, don't oversleep. Okay, just to cope up with this tiredness. Okay, and we have support groups as well. Okay, so you can join these support groups. Am I clear? And I think you guys are done with the learning disability already, so there's no need to discuss those cases. Oh dear Lord, now I'm tired. And you guys must
I
be.
have a question.
Yes, please.
With regards to otitis media, basically I think it's viral. So do you need to give
Yes.
antibiotics?
No. As I mentioned that in acute otitis media, you don't give antibiotics, okay? Because most commonly the cause is viral, okay? The only the only conditions in which you have to give antibiotics is if the patient is having discharge, because then you are worried about bacterial infections. If the patient has discharge, then give antibiotics. If the patient is having this ear pain or fever for more than or equals to 4 days, then give antibiotics. And in children, if there is bilateral otitis media and they are less than 2 years, then give antibiotics. Other than that, no need to give antibiotics.
Okay, thank you.
Because the cause is viral.
Okay, then secondly, all these presentations, would they be uploaded to us?
Sorry?
Even the previous ones?
Can you please ask the question again? I cannot hear you properly.
No, I'm asking to this class and all the previous classes, maybe the ones that we missed because of our job schedule. Are we going to have all the previous classes as well?
All the classes are recorded. So
are they uploaded?
Yes, I guess. I guess till yesterday it was uploaded, but I think by the end of this the night, these classes will be uploaded as well.
Okay, thank you.
Okay. Thank you so much for the talk class today. Okay, tomorrow we'll be discussing some LGBT related cases and some cough related cases. Okay, so tomorrow we won't be having long class. Okay, it's going to be a short class, and highly likely there will be no SPD tomorrow. Okay, because I have another mentorship class today. Okay, so tomorrow there will be only it will be only 1 or not 1 hour, 2 or 2.5 hour class for the whole day. Okay, happy?
Thank you so much, Dr. Sophia.
Okay.
Thank you.
Thank you so much, doctors, for today. And we'll see you guys tomorrow on LGBTQ.